So I am Dr. Rache Simmons. I'm the Chief of Breast Surgery and Professor of Surgery at the New York Presbyterian Hospital and the Weill Cornell Medical College. I'm going to be talking today about hidden scar breast cancer surgery. Just as an overview on today's presentation, we're going to be discussing that you, as a breast cancer patient, should know your surgical options. I'm going to discuss some key surgical considerations. I'm going to discuss the hidden scar breast cancer surgery, and I'm going to suggest some questions that you might want to ask your surgeon. Having a diagnosis of breast cancer can be really overwhelming for patients. And when you go to see your surgeon, one of the first questions you really need to ask is, what type of surgery do I need? And they'll go over, they should go over at least, what kind of cancer you have, and perhaps about stage and about some of your surgical options. And of course, the main question is, do you favor a lumpectomy or breast conservation, or do you favor a mastectomy? And we'll go over that in more detail later on in this webinar. Another question that's important for you to ask, that's what some people are wondering about and often afraid to ask, is how am I going to look after the surgery? And patients sometimes say, oh, well, you know, it doesn't really matter. I just want you to cure the cancer. Well, we're planning on curing the cancer. That's not the issue. But you really will care 5 years from now when you're doing well, you're gone beyond your surgery, and you look at yourself every morning. So how you're going to look after surgery really is an important question to ask your surgeon. Patients often say, oh, I am so busy, I can't believe breast cancer happened right now. Well, breast cancer doesn't actually occur at a very convenient time in many people's lives. Maybe your daughter's getting married, you're about to start a new job, but what you need to realize is this is the most important thing in your life right now, is taking the time to have the surgery, to have the right surgery, and to treat your breast cancer, because that really is going to take you on for the rest of your life, and it's a very, very important decision. Will my surgery be effective? Well, of course, that's the most important question, is you need to cure the cancer. That's why we're all here. And you need to be asking the questions of, what's the best choice for me as far as maximizing my survival and maximizing my healthy recovery from this breast cancer surgery? And then where does this fit in the rest of my life? Well, often surgery can be just an outpatient procedure, and it really doesn't take more than a day to go in and have your surgery. There might be other treatments afterwards, which might include radiation therapy, might include chemotherapy, and those are all important questions to ask your surgeon, just so you and your family and loved ones can have a plan and have an expectation of what's going to be evolving over the next few days to weeks to few months as far as your treatment. So it's really critically important that you ask the questions and understand what your surgical options are. It's your life, it's your health, and it's important that you make yourself empowered by this. So take the time to ask the questions and to understand what your surgical options are. Talk to your breast surgeon, to the plastic surgeon, to the radiation oncologist. They should be readily available to talk to you before you've made the decision about your surgery to help you decide which surgery really is best for you. Get a second opinion. Patients often ask me, should I get a second opinion? I'm often a second opinion or a third or a fourth opinion from some other patient, and I think getting more information is always good. You may hear the same thing over and over again. That's fine. That just reinforces that it's the right decision for you, and it makes you feel more comfortable in making your decision. Sometimes you don't hear the same thing. You hear a completely different opinion from somebody, and that's important for you to consider as well in making the right decision for you regarding your surgery. You really do have a choice in the procedures that you're going to have to cure your cancer. Now, when you are making these decisions about your surgery, it's also really important to ask not just what kind of surgery, it's also important to ask the question as far as what sort of decisions are they planning, because these scars are going to be with you forever, and it's important that you have realistic expectations as far as what sort of scars would be involved with the surgery that you're choosing. These visible scars really are a daily reminder of your cancer or your cancer risk. So any way that we can make scars minimally visible or ones that fade away that truly are invisible with time has a huge positive impact on a patient's self-confidence and her body image. It also has a huge impact upon the patient's feeling of intimacy and sexuality with your partner. And that's important. It's an important part of the survivorship after breast cancer. And this really is what lasts forever on these patients, is their feeling about themselves and their body well after they've been cured from the breast cancer. So what is hidden scar breast cancer surgery? Well, it's a way that we as surgeons can offer an advanced approach to removing the breast cancer, or in some patients, removing breast tissue because of a high risk of breast cancer. And it's a way that these incisions can be placed in a location that's either very hard to see or really completely invisible once it heals. And because of that, it really allows little or perhaps even no visible reminder that you had breast cancer surgery and that you had breast cancer, which is really important for a woman's well-being as time goes on after her diagnosis. And of course, it's as effective as traditional breast surgery. Patients often ask me that. They say, well, if I have this beautiful incision, is that going to be in any way of a negative consequence so that I'm putting myself at a higher risk of the breast cancer coming back or of not completely treating the breast cancer? What I tell them is absolutely not. These incisions allow you to have a beautiful cosmetic result without any compromise on the oncologic surgery as far as the effectiveness of treating the cancer and for your survival after this cancer. So breast-conserving surgery or lumpectomy is one of the options that your surgeon may propose to take care of your breast cancer, treat your breast cancer. And what that involves is removing the cancer with a marge of normal tissue. So you need to ask your surgeon, is lumpectomy a good option for me? Why do I need a lumpectomy? And in asking that question, often what your surgeon will say is to have a tumor that's found in a very isolated area of the breast, so one quadrant of your breast. If you think of the breast, as is shown here on this diagram, divided into 4 quadrants, typically if we have a tumor that's only present in one of these quadrants, then very often a patient will be a candidate to have breast-conserving surgery or a lumpectomy. This tumor may be a benign tumor, such as a fibroadenoma, or it may be a cancer that requires a lumpectomy. And then you also need to ask your surgeon, is not removing this an option? Sometimes tumors don't need to be removed surgically, and that's an important question you should ask your surgeon. For example, if a patient has a fibroadenoma, which is a totally benign tumor, often present in young women, and you have an image-directed biopsy, perhaps by ultrasound, and the diagnosis comes back as a straightforward benign fibroadenoma. Well, in many situations, we do not need to remove those surgically. You may choose to have it removed, or sometimes we think it is appropriate. So if, for example, it starts getting larger, or if it has a very irregular shape, or the pathology is a little questionable, then we would recommend removing those tumors. But often they don't have to be removed. So that's an important question to say to your surgeon, do I need to remove this? Now, obviously, if it's a cancer, the answer is going to be yes, that we have to remove those surgically for a cure from the cancer. So patients often ask, what is a lumpectomy, a breast-conserving surgery? Well, a lumpectomy is actually removing a tumor, as you can see here in the red on this diagram, with a portion of healthy tissue surrounding the tumor. That'd be the margin of resection. Especially when you have a cancer, you want to have a clean margin of resection. So that can be accomplished by either removing the cancer in one piece with tissue around it. What I typically do is I remove the cancer and then I go back and take separate additional margins to assure that I absolutely have a clean margin with these patients for their lumpectomy. So in breast-conserving surgery or lumpectomy, traditionally, many surgeons would place the incision directly over the tumor, which often is in a very undesirable location. And it may also be an area that is seen very easily in a blouse that's open or in a dress that's sleeveless, so that you'd be able to see these incisions and, again, just be a reminder that you've had cancer and may make the woman uncomfortable that people can see this incision and then know, oh, I had breast cancer. It also may just be an area that has tension when it's pulled by the weight of the breast, and could have stretching of the incision and cause a very undesirable looking scar. So here's an example of what I would really never do for a patient, is make an incision right over where she has the cancer. That would be a very unfortunate incision that she'd see as a reminder of her breast cancer forever. And again, this location may very well cause a stretching and not a very good-looking scar in of itself from the weight of the breast pulling on it. Hidden scar is a way that we're able to make incisions in places that blend in very well and make the incisions very, very hard, if not impossible, to see once the scar has healed. The three examples of where I typically make incisions are either up in the armpit area, which lends itself very well for a nice cosmetic incision because most of us have some wrinkles up there anyway. It's a great place to put an incision hidden in a wrinkle, and the patient won't even be able to find it a year later. The second option is around the edge of the areola, another beautiful choice for incision. And in many patients, especially if they have a fairly generous size areola, you can really reach anywhere in the breast through these incisions. So again, a very nice choice of incision that is very effective in a lumpectomy and also fades beautifully and is almost impossible to see in many patients after the surgery has been completed and the scar is healed. Option number 3 is down in the lower crease under the breast called the inframammary fold. And again, women have a natural wrinkle there anyway, so that's a great choice in making an incision to remove a tumor. And that incision can actually be a larger incision, and because of that natural wrinkle, it fades so beautifully that you can't even find it later. So that's a good choice to consider in a patient that either has a tumor in the lower quadrants or in a patient that has a large tumor that you want to remove with a nice cosmetically hidden incision. Now here's a video that we're showing a woman who has a tumor. As you can see here, the tumor in her breast, and this is in the upper outer quadrant of her breast. So for this patient, we really have 3 choices of incisions. We could do the periareola approach, which lends itself very nicely to a beautiful cosmetic incision and heals up very well, often not being able to find the incision a year later. Another choice would be the inframammary approach. So we make an incision in the crease of the breast, tunnel up, remove a tumor in that way. These incisions also heal beautifully. The third choice would be up in the armpit area, small incision and a natural wrinkle. This is a particularly good incision to choose if the patient is having a lumpectomy for cancer and a sentinel lymph node biopsy at the same time, because often this can be one incision to do both, taking out the sentinel lymph node and also to be removing the cancer through this very nice hidden scar type of incision. Now, mastectomy. So what would be the reasons that a patient would need to have a mastectomy? Well, one of 3 choices, really. Either the patient has a fairly large tumor, and it's not so much an absolute size, it's really a proportion of the size of the tumor to the size of the breast. So if we're going to be removing a substantial portion of the breast, then at that point I really encourage the patient to start considering mastectomy, because if you start taking out too much tissue and then you radiate afterwards, really patients would look better cosmetically just to have a good mastectomy and reconstruction than to remove a third or a half of their breast and then radiate afterwards. So size of the tumor relative to size of the breast can certainly be one indication for mastectomy. The other reason that we may choose a mastectomy is that the patient may have multiple tumors within the breast, and if you have multiple tumors, certainly in separate quadrants, then we really at that point recommend a mastectomy as the best choice for cure for these patients. The third reason that patients may choose to have a mastectomy is because of a very high risk of developing breast cancer, either a very strong family history of breast cancer or patients that have been shown to have a genetic predisposition with testing positive for BRCA mutations. And in those patients, when they appreciate the fact that they had a very high risk of developing cancer in their lifetime, they may choose electively or prophylactically, preventatively, to have mastectomies to avoid a diagnosis of breast cancer in the future. So what's involved with doing a mastectomy? Well, it is to surgically remove all of the breast tissue. And then breast reconstruction is optional, but most of my patients certainly do choose to have breast reconstruction. And I certainly encourage breast reconstruction in my patients and makes them really, I think, feel more themselves and more comfortable with their body after having had a mastectomy. There's been an evolution in these surgical techniques for mastectomy, really involving taking out less and less skin and leaving the nipple and the areola. The first mastectomies that were done, and this is talking about as early as the early 1900s, was the modified radical mastectomy. And this was a surgery that removed all the breast tissue. It removed a generous amount of skin, removed the nipple and the areola, removed all of the lymph nodes in the armpit area. And it was an effective treatment for breast cancer. But what we began to appreciate was that we really didn't need to remove all of this skin. So the next step was what's called a skin-sparing mastectomy, where we removed the nipple and the areola and a much smaller area of skin. And what we found was that the patients really did just as well, and they looked so much better by saving the skin envelope, because then it actually was much easier for the plastic surgeon to go in and just really fill this envelope with either tissue from the abdomen or other parts of the body or with some sort of an implant. And the cosmetic results was far superior to taking all of the skin, and the oncologic results were identical to taking the skin in a modified radical. Then the next step was we said, well, maybe we could actually start saving the nipples in these patients. And so that really became a trend to try to make the cosmetic result for the patient the best by saving the nipple and the areola complex. It certainly can be reconstructed by a plastic surgeon, but it's never as good as your own nipple and areola. It's really matching your opposite side for symmetry. And so then we have done this now for over 10 years, and we have very good data from large trials, including our own here at Weill Cornell, where we've shown that saving the nipple and the areola has any negative impact as far as survival or as far as local recurrence. So the results are equal from an oncologic standpoint, and they are far, far superior from a cosmetic standpoint in the patient's recovery and the way they look afterwards. And patients have been very, very happy with the technique of nipple-sparing mastectomy. So traditionally, nipple-sparing mastectomy would be placing an incision on the side of the breast and perhaps going out, as you can see here, toward the armpit area. And yes, you are saving the skin, you're saving the nipple, and that's certainly better. That's an advance in what we were doing before, and taking all the nipple and just saving the skin. But unfortunately, that scar is still visible when it's healed. So another technique that is much, much better is the hidden scar nipple-sparing mastectomy, where we place the incisions in ways that they're very, very difficult and impossible to see. And that would be typically done with the inframammary incision. So through that incision down the crease of the breast, I remove all the breast tissue, just like with a regular mastectomy. I save all the skin, I save the nipple, I save the areola, with the caveat that I always remove and test the tissue that's right behind inside the nipple itself. Now, if it comes back as benign, in most cases it does, then I'm perfectly fine saving the nipple and the areola. And as you can imagine, there's a huge cosmetic advantage to the patient by not just saving all of her skin and saving her nipple and her areola, but also having her incision hidden in this mastectomy. So once she has her reconstruction, you don't even see that incision. And patients tell me that they go see their internist or their gynecologist, and they just can't believe that patients have a mastectomy because you really can't tell that they've had surgery. Wonderful thing for the patient to be able to feel like herself and not have anybody know that she's had to have a mastectomy or that she had breast cancer. So here's a video showing the technique in hidden scar mastectomy. This is a patient who has multiple cancers within her breast. And so because of that, her surgeon has recommended that she undergo a mastectomy. Now here's an example of a traditional mastectomy with an incision across the chest, not saving the nipple and the areola, and then that would need to be reconstructed down the road. Here's an example of a nipple-sparing mastectomy, but with a horizontal type of incision that's going to be visible, and the patient will see that through the rest of her life. A much better approach is for the patient to have an inframammary incision, one down the crease of the breast, to remove all the breast tissue through this incision, and then have reconstruction through this incision. And the scar really fades beautifully. The patient doesn't even see the incision, and no one has to even know that she had a mastectomy. And very often, I can also do a sentinel lymph node biopsy through that same incision, so there's no additional incision to be added for the patient. That would be a visual reminder of her breast cancer for herself or for anyone else. So breast reconstruction is a very important part of the hidden scar technique with mastectomies. And it really allows the woman to feel whole again. It's honestly the rare patient of mine who does not have immediate reconstruction. And I think that's a wonderful option for patients to be able to undergo. So, of course, why do you need reconstruction? Well, you don't need reconstruction, but I think that most patients want reconstruction, and insurance pays for reconstruction. There's no disadvantage. It's a way to restore the natural shape and size of your breast, look like yourself again after having had a mastectomy. And patients often ask, is that going to be a problem as far as increasing the chance of having my cancer come back? The answer is no. Is it going to be a problem as far as being able to detect a recurrence? Should I ever have a recurrence? The answer to that is also no. Patients ask, well, maybe I'll do it later and not do it now. And I say, well, you can always do that, but if you do the reconstruction later, there's going to be several disadvantages to you. Number one, why go through 2 surgeries instead of 1? Secondly, you're going to feel the absence of that breast emotionally until you have the reconstruction. And then the third reason is that we will never be able to do as good of a job doing a reconstruction down the road after ostomy than doing it at the same time. Doing it at the same time, we can save all of that skin, save the nipple, save the areola, and have the plastic surgeon reconstruct the breast at that time and give you a much more natural and cosmetically appealing breast than you would ever be able to have as a delayed type of reconstruction. There are different types of breast reconstruction. One is implant reconstruction, which is a wonderful way to do the reconstruction for many patients. And it may be putting in the implants at the time of the mastectomy, but more often what the plastic surgeon chooses to do is put in what's called an expander. It's basically a temporary implant that goes in at the time of the surgery. And the reason is that the final implant has to eventually go behind the pectoralis muscle on the chest. And you have to create a space for that muscle. And so what the expander does is it goes behind the muscle at the time of the mastectomy, and the plastic surgeon typically will inflate that expander by putting saline into it to maybe half the volume of your natural breast at the time of the initial surgery. And then what happens is over the course of weeks to months, the plastic surgeon will then insert a little needle into the expander, inject saline, and stretch that pocket. We're not really stretching the skin because I'm leaving all the skin. That's not the issue. We're really just stretching that muscle. And how fast that happens really depends upon how big you want to be, as well as how fast your muscle stretches. So it can be weeks to months. And then you would go back for a second, typically outpatient surgery, and have the plastic surgeon exchange the expander for the final implant. It's usually done as a 2-stage. A lot of it is because it's just hard to create that pocket at the time of the original surgery. And I think also it's hard for the plastic surgeons to both stretch and shape at the same time. So I generally favor a 2-stage with an expander followed by the final implant, unless someone has very small breasts where we're doing really very, very little stretch of the muscle. But that's a question you really should be asking your plastic surgeon. Does he or she think that you're a candidate for 1-stage, or do they recommend a 2-stage reconstruction for your implant reconstruction? The other option is a tissue transfer, and a tissue transfer is really taking fat from somewhere in the body, perhaps some muscle with it, depending upon the kind of tissues being removed, and filling the volume of what used to be your breast with that fatty tissue. And one of the most common ways this is done is by taking abdominal fat. So it's essentially the same thing as what would happen if you went to a plastic surgeon and said, I want to have a tummy tuck. They'd be removing that little bit of extra tissue, and most of us have a little extra down there, and they take that tissue and they move it up and they make a new breast from it. And that can be done either with keeping the blood supply attached to the muscle. That's called a pedicle flap, Or they can also do it what's called a free flap. So they detach the blood vessels and they reconnect them up in the chest area. They both work very well, both of these techniques. So it's really important that you ask the plastic surgeon what sort of tissue transfer are they anticipating is best for you as far as your reconstruction. With a traditional nipple-sparing mastectomy, there is an incision that is used that is visible. And as you can see here in this diagram, typically this would be an incision that is going from the nipple area out toward the armpit. In contrast to that, a hidden scar nipple-sparing mastectomy uses the inframammary fold as the incision, and the scar is hidden when it's healed. So here also is an example of a hidden scar mastectomy. The incision is down at the fold of the breast, inframammary fold, and once the reconstruction takes place, this scar is very well hidden and almost impossible to see in most patients. So questions to ask your surgeon. The first question is, what type of cancer do I have? And you can say, how serious is this? What stage is it? You can ask about different kinds of grades. And what does your surgeon anticipate will be your prognosis? And also, what does your surgeon recommend as far as types of surgery? And ask questions. Ask, am I a candidate to have breast conservation? Am I better served with a mastectomy? And why? Then it's really important to ask what your scars are going to look like. Where does your surgeon plan to place the incisions? Because once those incisions are there, you can't undo them. So it's really important that you understand and anticipate and agree with where your scars are going to be in your future. Will people be able to tell that I've had breast surgery? Well, a lot of that depends upon where the incisions are placed. And the hidden scar technique is a wonderful way to be able to have those incisions so that you can't see them years down the road, nor will anybody else be able to see those incisions. And so ask, am I a candidate to have a hidden scar nipple-sparing mastectomy or a hidden scar lumpectomy? If your surgeon doesn't know about hidden scar and doesn't understand what you're asking, then that probably is a good time to go have a second opinion, to talk to a surgeon who does understand these options for you. Because if you're a candidate, it will give you a significant cosmetic advantage to have the type of incision that is a hidden scar type of incision. Obviously, you have to ask, is this going to be an effective way to take care of my cancer? And generally, the answer is yes. There are very few patients who have breast cancer that I can't offer them some sort of a hidden scar surgery. So this is another important question to ask your surgeon, but in most cases, we are able to offer patients hidden scar surgery and give them a beautiful cosmetic result from their cancer surgery. You can know your options and have choices in your surgical care. Scars really do matter. You may not think it does now, but 5 years from now, when you've been cured from your cancer, you will care where your surgery was done, how your surgery was done, and incisions that were made, and what scars you're left with for the rest of your life. Ask your surgeon if you're a candidate for a hidden scar surgery, and discuss with your surgeon the options available to you and how is best to treat your breast cancer. For more information about hidden scar, you can visit breastcancersurgery.com.